Now it is my pleasure to turn the floor over to Maurice Mendenhall to formally begin the meeting. Thank you.
Great. Thank you, Chris. And welcome to our 32 participants. As Chris mentioned, this is the fourth session in a series of social service workforce webinars, which are funded by the President's Emergency Plan for AIDS Relief and implemented onto the auspices of the Social Service Workforce Strengthening Alliance by USAID partner CapacityPlus. Today's session is also co-hosted by the Community Child Protection Exchange Forum, so we're really happy to have some new participants with us today. This session will focus on how to work with community members and community-based workers in the social services workforce, a topic that has come up again and again in our conversation with colleagues who are engaged in this work. Given the level of interest, we'll be holding two webinars on this topic this week, a session in English, which obviously will be held today over the next 2 hours, and a session in French which will be held this Thursday at the same time. Given that most of our sessions up until this point have featured case studies from English-speaking countries, our speakers today will represent two French-speaking countries, Cote d'Ivoire and Haiti. However, be assured that today both presentations will be presented in English. This session will be chaired by Sarah Lilley, and Sarah Lilley is the Child Protection Learning and Impact Assessment Advisor at Save the Children in the UK, and co-director of the Community Child Protection Exchange Forum. So as we mentioned, this is the fourth webinar in our series, and for those of you who are joining us the first time, we launched our webinar series in July of last year, 2011, with a session on lessons learned on the global healthcare workforce. This was followed by a second webinar in September on the social service workforce, various training curricula and tools for frontline workers, and then a third webinar in November which reviewed our accomplishments in this field since the Social Welfare Workforce Conference in Cape Town in 2010. So all sessions have been very well attended, and summaries, PowerPoints, and a recording from this session can be found on ovcsupport.net, where we will also post information about this session and future sessions. For those of you who are unfamiliar with ovcsupport.net, please note that the website includes a range of resources and information on how to engage in social service workforce strengthening initiatives, as well as more general information on programming for vulnerable children. Unfortunately, most of these resources are in English. However, we are eager to increase the number of documents posted in other languages. So if you have additional resources that you would like to share in English or any language, please send them to ovcsupport.net at msh.org. So I'm just going to walk through a few of our initial slides. Well, we wanted to give a warm welcome to all of you who are joining us from countries all over the world, it looks like today, primarily from sub-Saharan Africa, but I know that we have others that are joining us from West Africa this time, so that's very exciting. We wanted to just run through the agenda so that you can know exactly what's going to happen over these next 2 hours. As we mentioned, Sarah Lilley is our chair, and she will be providing some opening remarks. And then our first presentation is going to focus on lessons learned from the human resources health sector, but specifically going to focus on community health workers and what we have learned about working with community health workers, which is a cadre which has many similarities with a cadre within the social service workforce that we're most concerned about. Jim McCaffrey put together that presentation, but unfortunately he's not going to be able to join us today. So Maurice Middleberg, who is the director of CapacityPlus, is going to be doing that particular presentation. And then we'll have an opportunity for questions and answers. And the next presentation will be about Haiti. And our colleague Serge from the International Rescue Committee is going to talk a little bit about his experiences working with community members and community-based social service workers in Haiti. Again, we'll have an opportunity for questions, about 10 minutes, and our final presentation will focus on lessons learned in Cote d'Ivoire. And Hannah Newth from Save the Children is going to talk to us a little about her experiences and the experience of her organization. We'll have, again, an opportunity for clarification questions and then hopefully an opportunity for more discussion. during the final minutes of our webinar today. Sarah will provide us with a few closing remarks, and will also provide a bit of information about upcoming events. Just as a reminder, you can feel free to write questions or comments in the chat window throughout the webinar. We welcome that, and we'll do our best to address these questions following the presentations, and if not during that period, then during the discussion. So at this point, I'd like to welcome Sarah. Sarah will provide us with a few opening remarks and get us started today. Sarah?
Okay, thanks Maurice for the introduction. I hope you can all hear me today. Perhaps you could put up some smiley faces if you can hear me okay. Great, thank you very much. So I'm really pleased to be opening and chairing this session today, because I think it's such an important topic, and one, as Maurice, you said, we've been discussing a lot in the past few months and even the past few years. As we know, community members are a really large and vital resource to draw on for the protection of children and for strengthening the social welfare sector, and they form a key element of any national child protection system that we're working in. Parents, families and community members, whether it's in urban or rural areas, are the front line for the care and protection of children, as we know. And in an effort to ensure that basic social services are available and accessible for children and families, many governments and organisations are therefore engaging with community members to try to establish models of community-level service provision. I think over the past 5 years or so, we've seen a range of different models being tested, from the establishment of parasocial workers in communities, to the piloting of community child protection focal points, outreach workers, and other forms of paid and non-paid community protection and social welfare worker. So it's a really key element of what we've been doing, and working with community members is really at the core of the system strengthening debate, I think. And before we move into the presentations, I wanted to just share a few questions, 3 key questions really, that we're discussing and grappling with in Save the Children, particularly across our child protection work globally. And I think we'll discuss each of these issues in a bit more detail today, but I just thought I'd share some initial thoughts from the evidence that we're seeing across our programs. So the first question that we're discussing is about what the roles and responsibilities of community volunteers or parasocial workers should be versus the roles and responsibilities of statutory workers in a child protection system. And in particular, we're asking, what are the boundaries of the role of these community workers? What should they be doing, but equally what should maybe they not be doing, and what should be the role of the statutory workforce. Generally, I think we're viewing the community worker model as a complement to the statutory social welfare workforce. However, in practice, in Save the Children, for sure, we've seen some community members working actually as a replacement or gap filler for statutory roles. And I think in the sector we have some way to go in identifying and exploring how a complementary system for child protection between community members and statutory workers can really work in practice. And that's, I think, a great opportunity today to discuss and share experiences of that complementary or perhaps non-complementary process working. So the second question and challenge, I think, that we've been facing is around payment of community workers, and we're going to have an opportunity to talk about this in a panel discussion at the end of the session today, because it's so key, I think, to many of the discussions we've been having. We're frequently asking, how much can you really expect from a community worker who is unpaid? And I think most commonly from what we've seen in Save the Children's programs, the community workers that we're working with are either unpaid or paid a very small or in-kind payment. And we have contradicting evidence on this issue, on whether payment is a good or bad thing, or somewhere in between, or the benefits and cons of payment. So I think this is an area where discussion, testing and learning from other sectors can really begin to help us identify effective practice and guide us and governments and other organisations in the work that we're doing. The final issue that I wanted to raise is around the level of training, support and supervision required to really enable community members to fulfil the frontline function that's being asked of them. We know delivering quality assured community-based local services for children does require a skilled, trained and competent set of people on the ground at the point of initial vulnerability and contact. And this element of system strengthening is essential for child protection to really become a reality. I think again at this point, however, we're still trying to figure out as a sector what the optimal model of support and supervision should look like depending on the context in which we're working. So that's just a brief flagging really of 3 key issues that I think are really important in this discussion and area of work, and I'm sure we'll be coming back to them over the course of this session. So this is a new area, I think, for the child protection sector and for the social welfare sector. And in that respect, we do have a lot to learn from other sectors, such as health. And it's a wonderful opportunity to have Maurice Middleberg with us today from CapacityPlus to talk about lessons that are emanating from the health sector, which has a long experience of engaging community members and outreach workers in system strengthening. Maurice is the director of the CapacityPlus project, which supports human resources for health, as well as the social service workforce strengthening initiative. And today Maurice will be sharing with us, as I said, lessons from the community health worker model and implications that we can consider and bring over in relation to social service workforce strengthening and particularly the child protection community worker strengthening. So on that note, I'd like to hand over to Maurice to take us through the first presentation. Thank you.
Well, Sarah, thank you for that lovely setup and very eloquently put in terms of the challenges and questions and dilemmas that are facing the social service sector. And what I hope to be helpful with here is to share some lessons learned from the community health worker experience. As Maury indicated at the outset, my friend and colleague Jim McCaffrey was going to give this. Unfortunately, he's taken ill and so won't be able to do it today, so I'm stepping in his stead. This issue of community health workers is not a new one by any means. In fact, one can reach back to as early as the 1960s for the beginning of the modern experience with community health workers. And all of that now, almost 50 years of experience, has generated just a vast literature. Much of it is gray, but there is actually quite extensive published literature in the journals, in the professional literature about this. And the Global Health Workforce Alliance undertook a systematic review of that evidence in order to try to derive some learning that could be widely applied. We at CapacityPlus then built on that extensive community health worker literature review in an attempt to put forward some basic models and frameworks for community health worker effectiveness and productivity. This is in turn shaping our work as we collaborate with countries in their efforts to integrate community health workers as part of the health teams that serve communities. And I do want to underline that they need to be seen not as isolated providers, but as members of a broader health team who play a particular role in delivering essential care. Oh, wrong way. Chris, I need a little bit of technical support here. I seem to have jumped somewhere ahead in the forgive me, folks, but we seem to have a little technical problem here with the oh, there we go. Sorry for that delay. If you're interested in looking at the literature review that was commissioned by the Global Health Workforce Alliance, here is the citation. Of course, you don't need to take this down right now. As Chris indicated earlier, all of this information will be available to you subsequent to this seminar. So you can go and do the review of the literature yourself, and the citation is available to you. And here's a quick summary of what we're going to talk about today. The fact is that community health workers and community health worker programs have proven to be an invaluable resource in generating health outcomes. They have been important contributors to the declines in child mortality that we have seen. They've been important contributors to the improvements in reproductive health that have been witnessed. So they do have a vital role to play in achieving the Millennium Development Goals. But it must be recognized that community health workers are not a panacea. They're not a substitute for a full health workforce or for a functioning health system. And if they're not managed properly, in light of the evidence, they can quite easily fail. And there are many examples of failed community health worker programs as well as many successful ones. And what we're going to try to lay out today and concentrate on are what we see as 5 key factors that help determine whether or not a community health worker program will be successful. And these 5 factors, which you now see before you on the screen, are providing the essential policy and leadership support, clarifying the role of the community health worker, fully engaging the communities in which the community health workers are embedded, the management of the community health worker, and, as I alluded to earlier, fully integrating community health workers into the primary health care team. And what I'd like to do now is to walk through each of these 5 elements and share with you some of the essential findings. Now, with regard to policy and leadership support, like all issues, frankly, in the health sector, it is essential that this move to the top of the political agenda. The support of the leadership is essential. It must be both public and clear to the bureaucracy that CHWs are an important part of the overall sector. That symbolic work should not be underestimated in its importance. And accompanying that is the shaping of the policy environment for community health workers. And this often entails changes to law and regulation that help define the specific role, profile, and tasks of the community health worker. Now, typically this is not without controversy because there are often embedded advocates and lobbies that have fears or want to constrain in ways that are not supported by the evidence the role of the community health worker, and negotiations are typically needed in order to arrive at the right kind of policy framework for community health workers, but those changes are in fact essential. And the community health worker program can't be seen as something apart from the broader health sector. Again, it's not a panacea. It does not stand on its own. Rather, it is a part and parcel of a broader health strategy and must be constructed in that way. And very importantly, there must be an understanding from the outset that the community health worker programs have to be driven at the community level and be accountable to the community. So yes, they are overseen and managed and supported by the health system, but they really in the end have to be accountable to the community and be linked, as I'll discuss in somewhat greater detail, to the needs and relationships with the community. I talked a little bit earlier about the key elements of the role. It is the literature is quite clear about this, that the community health workers need to be selected from the communities in which they will serve with the support of the community. That cannot be selected arbitrarily by the authorities in the health sector. Rather, there must be a process that engages the community in identifying and nominating the community health worker. Very important that the tasks of the community health worker be clearly defined, that they have a clear job description. Programs that have failed have been ambiguous about what exactly community health workers are responsible for, and I think that's an important lesson for the social service sector. And one common failing, it's an easy trap to fall into, is to give the community health worker too many tasks and responsibilities. What tends to happen is that the community health worker is often established by some component within the broader health sector, and then other programs see that an infrastructure exists. So the origin of the community health worker may be, for example, in the maternal and child health program. Well, then the neglected tropical disease program, or the non-communicable disease program, or some other program says, oh, why don't we just add other tasks to that of the community health worker, and suddenly you have the case where 2 or 3 dozen different tasks are actually laid upon the community health worker, and that just doesn't work. What happens is the community health worker basically says, here are the 2 or 3 things that I am prepared to do, and you get passive resistance, and in the end the program just collapses. Interesting that Sarah brought up the issue of compensation. I think that there is widespread agreement from the health sector that community health workers have to be compensated for their work. And by compensated, we mean receiving regular remuneration for their work over time, that symbolic compensation like T-shirts or backpacks, that really is not a sustainable solution. So this issue is one that has been dealt with, and there's pretty extensive research around it, and that there is, in fact, need for regular compensation, even if it's at a modest level. And that is linked to this next point, which is the importance of retaining community health workers over time. If community health workers basically cycle in and out at a rapid clip, you don't get sustainable impact in terms of health outcomes and health performance. So there have to be incentives that retain the community health worker in their post, and this has to do with the compensation package. I mentioned earlier the importance of the community health worker being fully embedded in the community and responsive to the community. As I indicated before, communities have to be involved in the selection of the CHW, and they should also play a role in oversight by providing feedback to whoever is the supervisor within the health system, so that there is awareness of the performance of the community health worker that's generated by the community. And where there is positive feedback, that ought to be built into the reward system for the CHW, as that has important impacts on motivation and performance, and helps build the bond of trust between the community and the community health worker. The management of this CHW is also a critical element. Here, this is the same sort of meticulous work that should go into any element of health sector performance planning. Setting clear objectives, budgeting appropriately, having a way to monitor performance. All of these elements of management, good supervision, they need to be put into place for the CHW program in the same way that one would for any other element of the health sector. Now, in some ways, this may appear to be stating the obvious, but too often there's sort of a burst of enthusiasm about the CHW program, and what doesn't happen is the systematic management of the community health worker over time, being sure that provision is made for contact with supervisors, for refresher training, and so forth. That management includes building a bond between the health professionals and the community health workers. Again, I come back to this notion of creating a health team where the CHW is a respected member of a broader team, and the composition of that team is built in reaction to the burden of disease, that is the epidemiology of the communities to be served, with specific tasks assigned to the CHW where their skill sets will have the greatest impact on the burden of disease. And very critically, supportive supervision is essential. That is the bridge between the health system and the community, so that training people, supporting them, providing the necessary wherewithal, including petrol where that's needed or other forms of transportation, is really an important part of being sure that community health workers are managed effectively. And again, I come back to this notion of being sure that community health workers are fully integrated into the PHC team. While there are specific responsibilities that can be designated to the CHW, that has to be part of this broader set of tasks, and the CHW should be part of the conversation within the team that helps with the allocation of responsibilities so that everyone is clear about their role within that health team. So that's sort of a summary of some of the key findings from the literature. Now, of course, getting to the place that I've just described is often quite challenging. We really need to have a good conversation about it's one thing to say political and leadership support is needed. Then the question is, how do you get there? What are good advocacy strategies for achieving that? We do believe that regular compensation is important, but of course that poses real challenges for national budgets. At what level, what type, who should provide it, how does that get incorporated into national budgets? Those are all thorny questions. This question of we say there should be a supervisor within the health system, but again, it is on the one hand, the community health worker has to be responsive to the community, but also has a relationship with the more formal sector, and so there needs to be a balance there, and constructing that balance can sometimes be tricky. And what's not quite as clear within the social service sector is what is the equivalent of the PHC team that would include community health workers. What's the counterpart social service team, and who else would be in that team? In the health sector, it's more or less clear what the composition of that team might look like. I think that in the social service sector, that is still a question that is being wrestled with. So that sort of wraps up my presentation for today, and at this point I'd be happy to take questions or comments.
Thank you very much, Maurice. And Maurice, for those of you who are bilingual and want to log into the webinar again on Thursday, Maurice will be giving this presentation again, but he'll be giving it in French. We do have time for a few questions here, so we would encourage you to go ahead and write those into the chat room as they come to you. And if we have some time, perhaps we can also offer an opportunity for people to raise their hands and engage their microphones and talk with Maurice directly. We'll provide a few minutes for you to think of questions and write them in the chat window. I see we have one from Sarah. Let's begin with Sarah's question. Maurice, Sarah asks, in the CHW model, in the community health worker model, are there community health workers, are the community health workers that are usually recruited or managed and paid by the government or other organizations? And how do you ensure the sustainability of that particular model? Good question. Thanks, Sarah. Maurice?
Yes, thank you. It is a good question. Well, in large-scale programs, and there are a number of examples of this in South Asia, the community health worker is in fact paid by the government. It becomes part of the government budget and part of the government program, and this is where the sort of that basic policy decision-making that's needed. Now, it is also the case that there are ones that are community health worker programs that are sustained by NGOs, those that are able to sustain presence over time. And I guess what I would say about the sustainability issue is if we think about community health workers as different from other members of the health team, then we're setting them aside. That we're posing, in a sense, a question about the community health workers that we might not ask about a nurse. Now, of course, nurses, everybody agrees that nurses are vital to the health system. Nobody would say to a nurse, well, you're supposed to work a full-time job, or even if that person was working a half-time job, but we want you to do it in perpetuity for free. It's understood if they're going to work, they will be compensated. And the same principle basically applies to community health workers.
Great, thank you, Maurice. We have another follow-up question that has to do with the criteria for the selection of community health workers. Would you want to speak to that as well?
Sure. Interestingly, here there's a lot more flexibility, and it has less to do with the formal criteria. For example, should they have a secondary school education or primary school education or certain other kinds of qualifications of that kind. What seems actually to make the biggest difference is whether or not the person has been enthusiastically endorsed by the community. It's that level of trust with the community that seems to make the biggest difference. So if I was going to focus on anything, it would be on that relationship to the community that matters more than anything else.
Great, thank you. We also have a question about the range of responsibilities for community health workers, and so a question regarding whether there are any examples where a community health worker would focus on violence prevention or intervention services for victims of violence.
Yeah, I have to say in all candor that this is not an area that I know much about. I personally am not familiar with programs that have focused specifically on violence prevention and intervention, and perhaps someone else can be more helpful here. That I do know there have been some programs, particularly around gender violence and household violence, but my knowledge then frankly is pretty limited.
Sure. Thanks, Maurice. There's also a question here about remuneration, and any models for volunteer engagement and management. I noticed that you also use the term supportive supervision, which is one that we're hearing more and more, and I wonder if you could define that and discuss a little more about what that looks like within the field of community health care.
Sure. Let me address briefly the issue of volunteer engagement. Of course, there have been and are many examples of volunteer programs. But I think the experience with those is that they don't tend to function well over time. You get high rates of dropout, you don't retain them, and so the effectiveness is really quite quite limited. Now, with regard, Maury, to your question of supportive supervision, this really has to do with engaging the supervisor being in a role of counselor and coach and trainer rather than someone who is looking for error and chastising the community health worker. You know, on one level, this is what we all expect out of good supervisors. It's almost an intuitive understanding that we have about what constitutes good supervision. And so this does, however, that is not always the norm. And it does often require a reorientation of the supervisors of the CHWs, where rather than simply going down a checklist, it's really playing that coaching, counseling, and on-the-job training role. And that does relate actually to a question that was raised about training, that while typically what seems to work best is where you have relatively short-term training of the community health worker initially, but then there's continuing training that takes place on the job and through group meetings as these community health workers have contact with their supervisors and with the formal health system.
Great. Well, we have another question here, which is a very valid one, about how do you deal with small communities where there are only a few people who are literate, and therefore these are the people that are usually selected by the community to represent them as volunteers, particularly when records have to be collected and there has to be writing and reading as a part of their responsibilities.
Actually, there have been some very interesting efforts around this, and there are examples where the records use pictorial representations. In fact, the CHWs can be trained quite effectively to use the pictorial representations of services or commodities that were provided. So they really basically have to put an X or a check next to the pictorial representations, and then when they turn those over to the supervisors basically just aggregate the check marks in order to get a sense of the level of services that were provided.
Excellent. Good question. We have time for probably about one or two more questions, and I see that there are three from Lesotho. Let's see if we can combine some of those and get through those. But just to let you know, if you have any additional questions, please make note of those. And if Maurice, I don't believe he'll be able to join us for the discussion later on, but we will provide an opportunity for Maurice or Jim to answer those questions on ovcsupport.net in our discussion forum. So we want all of your questions to be answered. But Maurice, we have, as I mentioned, several questions from Lesotho here. Are there any examples of institutional arrangements that would link the formal social work community, I guess, with the informal community workers? So the volunteers would play the role of outreach workers for government, which wouldn't have staff, of course, at the ground level or at the village or community level.
Interesting. I frankly don't know a lot about this particular issue because I think the social work area is still very much in flux. I can draw some parallels with work in the health sector, where there have been arrangements made between the government and NGOs, where in a sense this gets contracted out to community-based organizations or faith-based organizations who then provide the institutional oversight that in the absence of really having a government presence. And sometimes there are national networks of organizations like women's groups who play that oversight role. So you get a relationship that's built between the formal health sector and either an association or a set of community-based organizations. So that might hold some lessons for the social service sector.
Great, thank you, Maurice. So I'm going to cheat a little bit and see if I can combine these final two questions and give you an opportunity to wrap up this question and answer period. So again, Lesotho was asking about examples of retention strategies beyond external funding, and then also had a question about the experience in getting communities to articulate and prioritize their health needs, and having community health workers align with these so that accountability, they can be held accountable, and it can be very clear about what is expected of them within a shared context.
Sure. Well, let me address both of these efficiently if I can. What I would say about the retention strategy is the most important lesson learned is ask the health worker. Don't presume that you know why they're leaving unless you've bothered to ask the question. Community health workers, like anybody else, are actual human beings, often with complex motivations. And if one begins to detect a pattern of attrition in that health workforce, it's important to ask the question, why is this happening? And it could be a compensation issue, or it could be a supervision issue, or it could be that something has changed in the external environment. So there's no clear answer to this question beyond the very important one.
We seem to have lost Maurice, which is unfortunate because I was really enjoying that answer.
Asking the health worker, that's what we've learned. Find out why attrition is happening directly from the people who are involved. And that often then leads to effective responses. Oh, I'm sorry, can you not hear me?
We
Hello?
can hear you now, Maurice. Continue.
I'm sorry, you're not hearing me?
I can hear you. Go ahead.
Oh, okay, okay. Well, anyway, I was just saying very briefly, ask the health worker with regard to, all right, and the experience in terms of articulating and prioritizing their health needs. Actually, I see my friend Umaru has put in a little note here. There are actually a whole set of techniques around participatory learning and action in which the community itself uncovers its needs and articulates them by using a set of techniques that are actually quite empirical. And it is that joint learning process where it is invaluable to have both somebody from the formal health sector and the CHW and the members of the community go through this sort of participatory learning and action exercise in order to identify what their needs are, what community-based solutions are available, and what is needed from the formal health sector. So my suggestion would be that the use of those techniques is the way to get at this.
Great, thank you so much, Maurice. This has been excellent. And Amoro, thank you also for your comment. I want to encourage all of you to, if you have answers to these questions, to go ahead and offer some of your insights and experiences within the chat window as well. We know that many of you are experts in this field as well. So Maurice, I know that you probably won't be able to stay on the line for much longer, so we just did want to thank you for stepping in today. You seem to be very knowledgeable about this topic, and so thank you for sharing all that you've learned and all that you know about community health workers.
It's been my pleasure, and I look forward to Thursday session. I wish you all it's been my pleasure, and I look forward to
Thanks again.
Thursday session. And I wish you all a good continuation. Bye-bye.
Excuse me. I wanted to welcome Serge Dalexis and say that we're very happy to hear from you today about your program in Haiti, particularly on the second anniversary of the earthquake in Haiti. So this is a very timely presentation. And Serge, thank you so much for your presentation. We look forward to hearing from you. Welcome, Serge.
Good morning, everybody. Thanks for joining this webinar session. I'm really happy today to present to you, everyone in the board, about the program that DRSC is doing in Haiti right now. So I'm Serge Dalexis, I'm a child protection manager. So today I'm going to present you the post-earthquake response for separated children and other affected children. It is but the part of this program that I'm going to present is the project Community-Based Child Protection, is the CBCP. And to begin, just to give you an overview about the earthquake happened in Haiti 2 years ago. As you might know it, we had about 300,000 of deaths and about 200,000 of injured people, and many destroyed houses and many losses of materials and so on. So now we have many NGOs, the government that are doing efforts just to rebuild the country, just to try to recover the economy and so on. And so now for this project that I'm presenting now, the objective is to promote and strengthen resilience among children living in displaced communities. So as you might know, right after the I was telling that for the objective one, we have providing activities like recreational activities, social support, non-formal education to boys and girls in communities and surrounding child-friendly spaces in where people are staying. And the objective 2 of this project is to reinforce community capacities to protect the children in a responsible and autonomous manner. So what we are trying to do is to strengthen the communities and to be able to respond to child protection issues and without calling each time an NGO or an INGO. And the objective 3 is to create a protective environment for children through autonomous and systemic community mechanisms. As activities, we have the training for dialogue group of discussion about child protection issues, and from these dialogue groups, we had selected community children protection community in camp where people are staying and or in the neighboring communities. And as targeted population, we are working in 4 communes, including 11 camps in the metropolitan area of Port-au-Prince, the capital cities. We have Pétionville, Delmas, Port-au-Prince, the downtown, and Tabar. So we are working actually with 3,829 children who have been registered in our CFSs, in the child-friendly spaces. So now let's talk about the community involvement. The community is involved in the project in the following ways. And for each child-friendly spaces that we commonly call CFSs, and there are 4 animators. The 4 animators are there to ensure the good functioning of activities in the CFSs, identify activities to undertake with children, observe children behavior, and signal refer if necessary. 3 security guards to help to maintain a safe, secure atmosphere in the CFSs during activities and look after the protection of the CFS space and materials. And also we have 1 monitor and to help to develop and helps to develop a work plan for the CFSs, submit requests for necessary material for activities, serve as links between parents, children, community members, and the CFSs. and these people are selected through a competitive selection process, including written and oral tests among the community members. Sometimes we also have animators or security guards that has been referred directly from community leaders. For example, each camp there are a community camp for management, so sometimes they refer people to be animators or monitor in our CFSs. After we have one parents community for each services. So right after the earthquake, to begin working in the in the camps, so we should find like an entry door. So we tried to set up a parent community for each CFSs, and these communities serve as, I can say, a filter unit for activities in the CFSs at the beginning of the project. So before running any activities in the CFSs, we try to pass by this committee, like a vetting committee, to see to give the approval of these activities in the CFSs. And after we put in place one dialogue group on issue related on child protection within 15 people per community camp. So these people are totally voluntary, really designed to participate in group dialogue using the ESK methodology. ESK means education is a conversation. So the ESK is in Creole we say education c'est une conversation. So this methodology has been developed by Beyond Borders, and we are working closely with Beyond Borders to develop this methodology to help people in community come to this methodology, and as a educating approach. And after, we have one child protection committee with 9 people from the community. This committee is composed of members of the dialogue group and are elected by the vote of the other members. And after, the activities in the CFSs are widely open for anyone, any people from the community who want to participate, want to give comments, want to share experience. They always feel free and to give to share experience and to give the words also to the activities in the CFSs. And as follow-up, and to follow up the activities in the CFSs, the RSC has four staff. This 4 staff is like these 4 staff these 4 staff are I can say fully employed by IAC, that they are full-time employee and they are working with IAC to supervise and to give support to the community, and while activities are running in the community. So we have one community mobilizer, one assistant mobilizer community, and 2 mobile social workers. The 2 mobile social workers have as principal role and to ensure that the community are referring case to the right people. For example, if we have child abuse, for example, sexual abuse, so these 2 mobile social workers ensure that the community reports the case first to the nearest hospital, and after make like psychosocial support to the child, and after go to see the local police, and after just to engage legal procedure. And key strengths, what we can present as key strengths for the program is that the program allows us to work with the social groups, social groups or level that are closest to the children protective environment. As you might know it, the protective environment of children has many cycles. The first one is the child, and after we got the parents, and after we got the community, and so on. So this program helps us to work first with the child in the community, in the child-friendly spaces, and after in the parent committee or in the dialogue group with parents, and after with the community. So also the program allows us to build a systemic approach by involving the community. So at the beginning, each time we have an issue about child protection, we had to refer, we had to do all the step directly. But now, since the community are trained on child protection issues, so now when there is any issues on child protection, they refer directly, and after they come to see what we can do, if we can help to have the process faster. And other key is that it is the involvement of the community on a basis of voluntarism. So as you might know it, if we had to pay each person to participate, for example, if focus group, in parent committee, and in that discussion group, so it will cost a lot. So, and this is a really key strength, since it is a way to help the communities to be trained and to keep moving forward after the project. So as challenges, it is to involve a little bit more the local, municipal, and central level authorities in the process. So at the beginning, it was really different. It was really difficult to have local or municipal authorities in the process. So now I think that they are more willing to involve in the process. So since we are working closely with the municipal authorities and at a central level, and we have direct communication with the local and with the government and with the central government, but we are trying to sensitize them and to help to make a link to link up them directly with the community. And as other challenge, it's to allow the community to make direct link with the available social service providers. And sometimes there is service available in the community, but the community members don't know to whom to address the cases, and they don't have system of communication, they don't have cell phone of service providers, they don't have email address of service providers. Sometimes it's really difficult for them to link up directly with the service providers. But that's the reason why each time they have a cases, even they know what to do, but they always come to see us to say, okay, we have these cases and we wanted to do this as steps, but the matter with that is we don't know how to reach the service providers. And after and other matters or other challenges that we are facing now is the massive withdrawal of services provider in the community and in the camp where people are staying. So as you might know it, right after the earthquake, we had a lot of service providers, a lot of NGOs, and so now it is not we have like an ongoing emergency. So we don't have a lot of service providers, we don't have a lot of NGO giving providing services in the camp. So now as child protection organization, we are winning a child protection project in this community. So they are trying to refer every case to us. For example, malnutrition, for example, sexual abuse for women, even if it's not the children, so they are trying to refer all the cases to us. So this is a challenge to help the community to find service providers, since now they are I can say backing off in the community. As prospect for sustainability, we are trying to set up a referral system at the local level for access to the available social services. Look, since the beginning of the project, we are trying to make a mapping of social services available, and to help the community to refer cases and to address the right people at the right time. And after is the making stakeholder, child, family, community, local authorities, central state are aware of the responsibilities in the implementation of the system. So sometimes when we are when there is a cases, for example, when they should refer to the municipal authorities, and they say maybe you have to go to see the central authorities, so we at a municipal level we can do much for you. So we are trying to create I can say awareness of responsibilities for each institution that might involve in the system. So just to give you a sense of the CFSs, and in the first pictures we have a wedding session and with children, and in the bottom we have our social we have our mobilizer, community mobilizer, that she is reading story to children, and in the last one we have children doing like recreational activities, like doing mid-man stuff. And what I can say to resume is from social support and non-formal education to recreational activities, the child-friendly spaces are an entry point into the community. And thanks to all, and now I'm waiting. If you have any question, don't feel free to ask.
Thank you very much, Serge. And also apologies for mispronouncing your name. Clearly, I'm not a French speaker, but that was an excellent presentation. I think we're all very encouraged by what you've been able to accomplish in Haiti. And at this point, I'd like to welcome any of you who have any questions for Serge and about the work that he's described to go ahead and write those into the chat windows. Perhaps I can start with a question about that liaison role between the formal and informal social, the community and the formal social service sector. I think you did an excellent job of describing the challenges of being in that position and serving as that liaison and trying to connect communities to government services and other social services. Have there been any techniques that have been particularly effective in trying to play that liaison role? And then what also are the plans for trying to make sure that this particular cadre, this role that these particular community members are playing right now, how to make sure that that's sustained beyond the life of the project? Serge, is that possible for you to answer that question? I want to make sure you're still with us because it seems like there are a few more questions as well. It looks like Serge is still logged in, but perhaps is having some difficulty with his microphone. If anyone else would like to offer any experiences or ideas about how to answer that question, and others that are coming in, if you'd like to raise your hand and engage your mic, perhaps we can invite you to share some of your experiences as well. We have some interesting questions coming in here, and perhaps it's useful to go ahead and share some of those for those of you who are not able to access your chat window. There's a question about the impact of dialogue groups and the methodology that was described and the benefits of having dialogue groups. There's another question here about specific roles and responsibilities as established for children and parents and families and communities and institutions, which are all part of the larger community. Our colleague Jane Warburton is reflecting that it's interesting that the lessons from the the community health worker experience around volunteers, that those are some interesting lessons, and that there might be some possibilities within the emergency context for applying some of those lessons, but not necessarily over time. Would anyone like to respond to any of these questions?
And thanks for these questions. I think that they are really good ones. And what I can say about the benefit of having these groups is that when we were trying to implement the project, so few people were aware about child protection issues. For them, child protection issues was only when we are trying to register a child in an armed group, and sexual abuse and things like this. So they didn't know much about child rights. So with this dialogue group, with the ESK methodology, we have the community really aware of what is child protection issues. The ESK methodology is not like a formal training, it's just like a discussion group where everyone can share its point of view of the thing, and after we got a moderator from ISC just to give direction to the discussion. So now they are reporting all the issues about child protection since they are trained. They know about child protection issues, and after we have the child protection community form these dialogue groups. So what after the dialogue groups, we after completing of the lesson in the methodology, we did like I can say that graduation for these people, and among them by a voting process we choose those people who will be the child protection committee. And now we have the child protection committee. They are like a watching dog in the community, and to look for any child abuse, any child protection issue, and to refer to local municipal authorities, and to refer to us also as child protection issue. And now they are trying to refer themselves and to they're trying to refer themselves to service providers. So I think that since they are aware of child protection issue now, they are doing the work by themselves, and they don't call us for each case of child protection issues.
Great, thank you very much. There's another question that I think is actually an important one to potentially pick up and talk about, but and it has to do with the potential for applying some of the lessons learned from community health care worker experience within the emergency context. So one of the things that Maurice talked about were these 5 factors that influence the success of community health workers as an intervention. Can you think about how those different factors might be applied within an emergency context, and how they might work, or how they may not work.
And I think what I can say is that since we are trying to involve the community members in the process, so it's easier for us to reach the community. So as an international NGOs, when we just come and everyone was waiting for help, and so when we choose some community members to work with the community, and they are pretty aware that we're not here to give help as goods and materials, and we are there just to, I don't know, deliver some background in child protection issues. So when we pass through community members to reach the community, I think that it's easier and it is more sustainable also. So the community is more willing to work with community members than to work with a full-time employee from RSC. And since the community members knows everyone in the community, and it is really easier to reach them through community members. So I think that this is one of the good points. The key strength of the program is that we are reaching the community through community members.
Great. Thank you so much. Thank you again for sharing your wisdom and your experiences. If there aren't any further questions, I'm thinking that perhaps we could move to our final presentation and then have a little time for discussion at the end of our session. So Serge, again, thank you so much, and we are looking forward to keeping you on the line today in case there are any further questions, and hopefully we can hear from you again at the end of our session. Thank you. So at this point, I would like to welcome Hannah Newth, and Hannah's going to talk to us a little bit about
You're welcome.
Wonderful. A little bit about building capacity for OVC care and support in 7 regions of Cote d'Ivoire. So Hannah, please tell us a little bit about your experiences.
Okay, a very good morning or good afternoon to everyone. My name is Hannah Newth, and as you've heard, I'm joining you from Cote d'Ivoire in West Africa, where I'm the OVC Program Coordinator for Save the Children. Save the Children's OVC program is funded by PEPFAR through USAID to build the capacity of OVC care and support in 7 regions of Cote d'Ivoire, as you can see there, the title. The program's been funded since 2008, so we're currently in the 4th year of programming. As the title of the program suggests, the main objective is to work with state and civil society actors to improve the quality and sustainability of care for children affected by HIV throughout the country. In terms of beneficiaries, the program aims, through its partners, to support at least 18,000 OVC this year. The main targets or collaborators for Save the Children's capacity building efforts are social work centres and local NGOs. This year we'll be providing technical and logistical and financial support to 11 local NGOs and technical support to 12 government social work centres. These structures then in turn work with community members and families to ensure appropriate care for children affected by HIV. In general, the programme follows the National OVC Strategic Plan and Guidelines for OVC care as led by the Ministry of Social Affairs. Although interestingly, and as I will return to later, there are no national guidelines for the involvement of OVC community, for the involvement of community members in OVC care. So what's the role of community members in our OVC programme? Community members are really at the very heart of this program. It simply wouldn't be able to function without the services they provide. We call them conseillers communautaires in French, which is community caregiver. We aim for a ratio of 1 community caregiver for every 40 OVC. And to date, we have 262 who are operational and working in their communities across the country. We don't give any specific requirements in terms of time that they should dedicate to the role each week. Some may condense it into 2 or 3 days a week. Others might prefer to spread out their tasks through the week. It's really up to them as to how they want to organize their time. A controversial and difficult question for our program has been the financial reward given to community caregivers. To date, we've been paying an equivalent of $50 per month to each community caregiver on the provision of their monthly report. Recently, we've been exploring other options with new project partners, such as providing startup costs for income-generating activities or for savings groups. So how are community members recruited into the project? We work largely in rural areas, and Save the Children has always insisted that children should be involved in the choice of community caregivers. So when we need to recruit new CCs, the partners will gather together groups of children, of boys and girls, usually between 10 and 17 years of age. They are then asked to choose the criteria or characteristics of the type of adult that they feel they can trust, and they are then asked to make a list of the adults in their community that they know who respond to their own selection criteria and who the children would then like to invite to become a community caregiver. So using this approach, the children put forward a list of adults. The members of the local NGO, so that their community members, will then check the list for suitability. In some large urban areas, this approach can be more difficult to apply when communities are not so tight-knit and children may not know the adults so well. So sometimes we do have to apply a more traditional application process with tests and interviews. We're starting to introduce a children's interview panel into this so to ensure that children are still participating in the final choice. So what's the role of community members in the project? The primary role of the community caregiver is to visit OVC in their home. That's to talk with them and their family so that they can identify any problems that the children may be experiencing and refer them to the local NGO and on to other appropriate care services. They offer psychosocial support and encouragement, whether that's relating to coping with the illness or maybe with their schoolwork, with healthy eating, a whole range of issues. They're obviously useful messengers and mobilize the community when there are events such as vaccination campaigns or distributions. Some of the community caregivers will help run children's clubs, life skill sessions or recreational activities, and some might also be involved in the delivery of certain services such as screening and referral of malnutrition, maybe cooking demonstrations or running awareness-raising campaigns. Importantly, they complete monitoring forms and monthly reports which document all the services that a child has received and the impact of the services on the child's welfare and progress. These are the monitoring forms supplied by the national programme. In terms of their training and supervision, firstly for their training, each new community caregiver receives a 4-day initial training course which focuses on child rights, the role of the CC, OVC care and the M&E tools that they'll be required to complete. They'll then generally receive between 3 and 4 further training sessions or refresher sessions during the year. In terms of their supervision, they're all attached to a local NGO which receives financial and technical support from Save the Children. Each NGO will appoint one supervisor for a maximum of 15 community caregivers, and this supervisor will then oversee the quality and regularity of the CC's work, ensure that they are supported with the types of issues they're dealing with, and check that their reports are being completed accurately. Most of our partner NGOs hold a weekly support meeting with their community caregivers to provide an opportunity to plan and report on activities and to discuss any difficult issues that the caregivers are experiencing. So the links with the government social welfare system. I think it's fair to say that the government social welfare system in Côte d'Ivoire is very poorly resourced, which is, I'm sure, a familiar situation for many of our listeners. The result is that it struggles to function effectively. Government social workers collect data on OVC, data such as the number identified and the number of services they receive from local NGOs and from the community caregivers, and this data is fed into a national database. Government social workers will also participate in the training of community caregivers, but only when it's financed by NGOs such as Save the Children. On the whole, the government social workers are not really able to offer direct services to OVC. It's clear that community caregivers with their local NGOs are playing a role in case management of OVC that would often be carried out by social workers in a better resourced social welfare system. So as Chris mentioned, we have a clear case of gap filling or replacement of government social workers. How does Save the Children's approach that I've just explained fit into the national picture? Community caregivers are not a role officially recognised by the national OVC programme. That's the Ministry of Social Affairs, their OVC programme. They've been introduced into adult care, but with OVC their role is not officially recognised. It's very clear that the state system would not have the resources to support a large-scale use of community-based workers, all requiring training and at least a minimum of financial reward, which probably explains why the government has not taken the lead in producing national guidelines on the role of community caregivers. So there are no national standards, no national guidelines or policies on the use of community members in OVC care in Côte d'Ivoire. The result is that many international NGOs operate a similar approach to Save the Children, but there are significant differences in the way they are rewarded or paid, and some differences in their role. Some NGOs, pay significantly more than the $50 a month offered by Save the Children, while other smaller NGOs, national NGOs, ask their community caregivers to work for no financial reward other than covering perhaps transport costs and training. So what have we found to be the strengths of this approach? Having community caregivers in this way allows for a larger workforce and a greater coverage, a much closer follow-up of individual children. So it's less likely that the problems of individual vulnerable children will fall through the cracks. It also compensates for a poorly resourced, understaffed social welfare system. Most of the social work centres, the government social work centres that we work with, will have only 2 or 3 staff who have no way of getting out into the community to visit beneficiaries. So our community members, being in the community already, are able to provide the support that government social workers can't. They're also a very useful workforce in raising awareness and understanding of HIV, of child rights, and of how to care for vulnerable children in the community. So the challenges that we've been meeting, as I mentioned previously, the fact that we pay community caregivers does throw up a number of challenges which are difficult to resolve. On the one hand, it seems difficult to justify not paying them. Their role is very demanding, and community members have become used to receiving payment from NGOs, especially recently following the influx of NGOs during our recent emergency response. So it's very unlikely that community members would work for nothing. On the other hand, paying community members leaves the impression that they work for Save the Children rather than for the local NGO that supervises them, or better still, for the community. Linked to this, the payment of community caregivers begs the big question of sustainability. Who will pay the salaries when donor money dries up? It's sure that neither the government or local NGOs in this context will be able to. At Save the Children, we've been working hard with our partners to raise awareness of this problem, but certainly solutions aren't easy to come by. The other important challenge relates to the monitoring and reporting requirements of their role. In order to comply with the National OVC Programme's reporting requirements, so that's the government's National OVC Programme, to comply with their requirements as well as to enable accurate reporting to donors, community caregivers are meant to record the needs they identify, the action they take, and all the different services provided to the OVC they visit. So the paperwork is heavy and it's complicated. And what's clear to us is that people who would provide the most caring and sensitive community-based care aren't necessarily the ones who can fill in complicated reporting forms. So this means that we're obliged to recruit educated and literate people, which can limit some people's involvement, and most especially the involvement of women. Finally, what are some of the important lessons we've been learning, although I was asked to pick out one significant one. I think we've really learned that the project's success or failure lies largely in the hands of the community caregivers. They're a very powerful workforce. They can be positive ambassadors for vulnerable children, but if they are demotivated, they can also damage the project's impact and reputation quite quickly in their communities. So in this respect, it's very important to invest in them in the way that you would with any of your salaried project staff, by providing training, by providing support, supervision, encouragement, acknowledgement of good practice, and they must have the opportunities to air grievances. So I think that's a really important lesson for us, that they must be treated as you would, along good practice guidelines, as you would for your own staff. So, thank you very much. I think that's brought me to the end of what I wanted to share with you today. Thank you.
Great. Thank you so much, Hannah. That was fantastic. Very inspiring. And so we have an opportunity now to ask a few questions of Hannah, to learn a little more about the program that she discussed and the interventions and her work and the work of her colleagues with community members who are engaged in social services and providing social services and caring for children that are orphaned and made vulnerable by HIV. Perhaps I can start us off while you all are writing your questions into the chat window. Hannah, we have heard previously a little bit about the social centers in Cote d'Ivoire, and I was curious to know how the community members that you work with are able to facilitate access to some of those services that are provided in the social centers, and what have been some of the advantages and disadvantages of working with those social centers or challenges. Could you talk a little more about that?
Yeah, sure. I think as I tried to bring out, the social centres in Côte d'Ivoire are really very, very poorly resourced. And when you ask me how a community caregiver is linked into the services they provide, I have to be very honest and say they're unable to provide many services. They provide services when NGOs such as Save the Children finance them to do so. So we will often provide nutrition demonstrations or awareness-raising activities or training of the community caregivers, where we seek to involve the social work assistants. We will plan that work with the social work assistants, but they're only able to put that in place because Save the Children finances it. So we facilitate as much as possible the social workers visiting the NGOs and the community caregivers. we insist that, we try to insist that social work assistants run any trainings with us for community caregivers. So we try and make that link as much as possible through the funding that our program has. But our concern is that in the future, if funding is pulled out for NGOs such as Save the Children, I'm not sure how that link between the community caregivers, the local NGOs and government social workers is going to carry on. Until government social centres are much better resourced, it's difficult to see that link. Maybe others have experience of having more success with that than us so far.
I think it's unfortunate that that these community caregivers are not recognized by the government, and you discussed some of the reasons for that. I know that in many countries, even if the community members that provide social services are not directly supported by the government, they are recognized. And we've heard about a few of those programs in South Africa and in Kenya. Could you talk to us a little bit about any efforts to try to get them recognized, or to find other kind of support from the government that's not financial?
Yeah, sure. Well, the invitation to participate in this gave me a bit of a boost to go and talk to the ministry last week, and I think that they definitely see the need to standardize the approach. They see that there are different international NGOs, as I mentioned, paying different amounts, asking the community caregivers to do different things, and having very different expectations of the role. So the government definitely do recognise the need for uniformity, for some minimum standards, and for some good practice guidelines in this area. And I'm confident that the NGOs will be able to work with them on this. I think that the difficulty is just how to see this role as sustainable. I can't see the government's social work system ever putting in enough money, at least in the near future, to make this role a role that is in the government social work system once donor funds pull out of this system. Has that answered your question a bit?
Great, yes, Sarah. Apologies, the questions were not coming through my chat window. I now see that we have several questions, which is great. So clearly your presentation has prompted a lot of interest. Let's begin with another question from Jane Warburton. And she's asking, what would it take to persuade the development donors to take on board the issue of child protection in the longer term? What evidence of positive results from this very concrete intervention would persuade them of the benefits? Do you have any thoughts on that, Hannah?
I think for us here in Cote d'Ivoire, that is certainly where we see one of the longer term answers, is that it's the role of INGOs such as us to do that advocacy, to persuade the development donors to be putting their money into the government social work system as much as into INGOs. Of course, we all recognise the reservations they may have around that, but I think that's where we see our role. We have a project running through till 2014 now. So I think that advocacy role is one that we need to be concentrating on as part of our exit strategy.
Great, thank you so much, Hannah. I think we have time for one or two more questions, and there are a few here. Maybe we can try to get through Amy and Andrew and Christine's questions, and then we'll move on to our discussion. So Amy Bess is asking a question related to, in each country, are there multiple NGOs supporting community level involvement? And if so, can you talk a little bit about NGO coordination and if similar models are being followed by NGOs, etc.? I know you discussed that a little bit in your presentation, but it's an excellent question, always a challenge. or if there are variances by municipality or district, are NGOs working together with the government to look at models for future standardization across the country?
In Côte d'Ivoire, I think this is exactly what needs to be happening. It's not happening at the moment. It's happening in other areas of the program, but on specifically the issue of community member involvement, it's something that does need to happen, and I'm really excited. Actually, the French version of this on Thursday, PEPFAR has got together all the partners to come and listen to it. So I think that's going to kick off a debate that's very much needed. So in Côte d'Ivoire, no, this kind of coordination hasn't been happening to date and does definitely need to happen, and I'm excited that we're at a point where it's going to start happening now. I'm guessing colleagues in other countries might have much more experience of this kind of coordination already taking place.
Excellent. So this picking up on a previous point, so are the CCs, are they linked to any local child protection mechanisms? For example, local child protection committees, or for case referrals or anything related to case referrals?
Yeah, I was probably a bit harsh when I said that the government social centres aren't able to do very much. Of course, they do manage serious cases of child abuse, and other NGOs will be linked into that referral system. So community caregivers are trained on how to respond when they hear or see a case of child abuse, and they will then report that straight to their supervisors in their NGO, who will then report it to Save the Children and the government social work centre. So that child protection system and referral system is in place. I have to admit that one thing that's happened in Côte d'Ivoire is that our child protection programme, which is actually a separate programme, has put in place child protection committees, and we haven't made good enough links. That's some learning we need to be focusing on. We haven't made good enough links between our child protection committees in the child protection programme and the community caregivers in the OVC programme. Of course, those links can be made, but the links into the overall child protection system in the country are there, and I'm certainly confident that if there was a case of child abuse, this would be reported correctly through our systems.
Great. Well, I think we have time for one more question. There are also a couple of great comments here about commitments that were made by the government of Côte d'Ivoire at the PEPFAR-supported conference in Cape Town 1 year ago, and also a recognition that it's difficult for national governments to own or sustain models that they didn't create. So a suggestion about for future programs trying to co-create these models along with the government. But there's a question again about linkages linkages seem to be kind of the theme for the day, but linkages between statutory qualified social workers and local NGOs, Save the Children, and the community caregivers to ensure that the correct standard of social work experience and the correct standard of practice. So is there common training? You talked a little bit about training, and how is this provided? Perhaps you could talk to us a little more about that, and then we'll move into our discussion phase.
Yeah, sure. So the government-trained social workers join Save the Children staff in all training given to community caregivers. So whether that's an initial training, as I mentioned, all community caregivers have an initial training that looks at child protection issues, it looks at how to report child protection issues, it looks at child rights, as well as looking at the role of the caregiver and care of OVC. So the government-trained social workers will join in that training. They will also participate in all subsequent training, refresher training. So they are going to be applying the standards that are appropriate to the community level member in those trainings. But I think we would need to be looking at some national minimum standards, as I've already mentioned, in order to be able to ensure that the community caregivers do all have a minimum knowledge across the country and across NGOs. So that's an area of work that is needed in Côte d'Ivoire, and to identify what those minimum standards are. I know that in child protection committees in some countries they've done a lot of work on minimum standards for child protection committees, and I think that same piece of work needs to be applied to individual community members in our programming.
Great, thank you so much, Hannah. It's good to hear that the rest of your Cote d'Ivoire team will be participating on Thursday in this discussion. I know that there are a few more questions that are excellent, and we'll make a note of those, and if we have an opportunity, bring them up again in the next few minutes. But we did want to recognize that many of you who are participating in the session have a range of experience with community members and social service workers, and would love to hear more about what you've learned. So for this discussion, we're going to have about 10 minutes to hear more from you, and we'd like for you to consider the following questions. And you can write your responses into the chat window, or again, if you would like to raise your hand, we can call on you, and perhaps you can talk to us a little bit about what you have, what you've done, and some of the challenges that you face, and some of the successes that you have experienced. So the first question is, what are some of the challenges and the successes that you have had working with this cadre, and what lessons have you learned that you might be able to offer other colleagues? So take a little time to discuss this if you're in a group, or think to yourself and write your comments in the chat window or raise your hand. Well, as you're thinking about about this question, perhaps we can go back to a question that I'm seeing from Sarah, who asked great questions. That's for Hannah, and perhaps we could also open this to others who might be able to answer this question. Do we have any evidence to show the impact of CCs on child protection outcomes? Great question. And if so, can we use this to advocate for, with the government, for funding for a model like this, and how can we do that? Or is that just unrealistic given the context? What will it take to enable governments to fund and manage these kinds of community worker models? And it's an interesting question given that our health colleagues have had some more success in trying to fund this particular cadre within the health sector. So Hannah, I don't know if you have any comments or insights into that, or Serge, or anyone else, but it's a good question. Thank you, Sarah.
Yeah, just to answer briefly. The indicators that we're using for impact, to show impact on our program, I don't think they would individually pick out, or they wouldn't necessarily pick out the role of community caregivers. So no, I have to say that to measure the impact specifically of a community caregiver on a child's progress or well-being, we couldn't do at the moment. We can measure the impact of interventions of overall support given to children, but not specifically of the role of community caregivers. So that's a very interesting point. Thank you, Sarah.
I see that we have a hand raised. Mark has his hand raised, and Mark, like Sarah, is a co-director of the Community Child Protection Exchange Forum. So Mark, let's see if we can let you open up your mic and talk to us a little about insights that you have.
It wasn't so much. Can everyone hear me? Click a smiley maybe if you can. Smiley is great. It wasn't so much insights. It's a question for the group and linked to what Hannah just said. What evidence do we have that community-based workers are improving outcomes from children, for children, and specifically for children's protection and well-being? And I would love to hear from anyone who's participating in the webinar if they've managed to produce any evidence, and if so, what evidence have they produced? I'll also type the question into the box so that it's there for others to see and think about.
It is an interesting question, and Mark, and both Sarah and Mark, thank you for raising it. And you know, a little bit later, we're going to talk about a kind of an initiative within the health sector to try to really collect and disseminate evidence around the effectiveness of community health workers. And so, you know, it's I think one of the challenges that we have had is finding evidence and kind of maybe across our sectors. And so, again, maybe we can learn about how that is collected and disseminated in other sectors. I see that Mike Wessels, that Amy has pointed out that Mike Wessels has published a report that's a great resource and has left a link there for us to take a look at. I don't know if anyone has any final comments. It's sometimes difficult to engage your mic and speak, but we are certainly happy to read out your comments if you want to type them into the chat window. Well, I recognize that we're actually running out of time, that we have been together for almost 2 hours now. So I'd like to give an opportunity for Sarah to perhaps say a few final words. And if there are some other discussion points that we would like to continue to raise with one another and discuss with one another, then we can do that in the discussion forum that you'll be linked to after this session. So Sarah, would you like to say a few final words?
Okay, thank you, Maurice. I hope everybody can hear me again. I guess just to start off by saying thank you so much to all of the presenters today. I think it's been a really fantastic and fruitful session and really shown a spread of the types of programs we're engaging in terms of community social welfare workers and child protection workers, and has also just given us, I think it's a really helpful step to look at the experience of other community health workers and to keep reflecting again on how the community health worker model developed. Definitely we should be looking at the types of evidence that were gathered around effectiveness, how the health sector went about gathering that, and consider whether we can do similar things in our sector. So thanks very much everybody for the fantastic presentations and discussion. I guess there's one key idea that I think I'm taking away today, and it does come from the comparison between the community health workers and the child protection workers, and it's really struck me, something that Maurice said earlier, which was that from the experience in the literature, it shows that community health workers cannot stand alone and must be part of a wider respected team and the wider health system. And I think that's so critical, and as Maurice, you said, the issue of linkages has come up through and through our discussion today, and I think it's just reiterated for me the importance of that issue of linkages and being part of the wider system and this wider team of social welfare workforce workers. So I think that's something that we need to be exploring further and looking at how we can gather evidence around that in child protection and social welfare, learn from the health sector, and also work maybe in a more participatory way with governments, as I think one of the comments somebody had said earlier, getting governments to take on and fund the system that they haven't been part of creating might be problematic, but building a system in a participatory, collaborative way from the outset would be a better approach. So I think that's a key message and idea that I'm going to be taking away from today. So yeah, I think we are really out of time now, so just to thank everybody again who has been involved in preparing for this session across the Social Welfare Workforce Strengthening Initiative and also the Community Child Protection Exchange Forum. Just to let anybody know who's not already aware, the Community Child Protection Exchange Forum is now launched and up and running, and we have a website which is childprotectionforum.org, and we'll send the link to that around to everybody, and we will be posting increasingly resources specifically on community-based child protection workers and mechanisms, and there'll be opportunities to share more practice and learning through that forum as well. So just to share that with anyone who's not already aware. So I think that's my final thoughts, Maurice, and yeah, that's it. Thanks everybody. Back to you, Maurice.
Great. Thank you so much, Sarah. We know that you and Mark both have been so engaged in the development of this particular webinar session, and we're very, very grateful for for finding our excellent speakers today and for your observations and for being here to host this session. So I just wanted to say a few final words. I wanted to pick on a point that I was making earlier about an evidence summit that is currently being developed by USAID on how best to support community health workers to improve their performance. So the evidence summit is expected to take place in spring and summer 2012, and I'm hopeful that we'll be able to share the results of that evidence summit, again on ovcsupport.net and perhaps on Mark and Sarah's forum as well, because I imagine that there are going to be some useful findings that could be relevant to the work that we're doing with the social services. So the summit will focus on the following questions: which community interventions improve the performance of community health workers? Which formal health system interventions improve the performance of community health workers? Which combination of community and formal health system interventions will improve their performance, and how are community and formal health system intervention structures and or operationalized to improve the performance of community health workers? So these questions seem to be relevant to the work that we're doing as well. At this point, I would also like to remind everyone that a summary of PowerPoint presentations and a recorded version of this webinar will be available on ovcsupport.net within the next week. There was a question about the recording. I want to assure you that that will be available very, very soon. Also, to join this listserv and to receive more information about future webinars and other relevant activities, please send an email to swws.webinars@capacityplus.org, and we'll try to keep you informed about new topics, new opportunities. Our next webinar session is tentatively scheduled for March 2012, and the suggested topic is the role of casework and case management within the social service workforce. Let me make sure that our PowerPoint presentation is caught up with our announcements. So if you or someone you know would like to make a presentation on this particular topic during the next webinar, or if you think you have any resources or tools that you would like to contribute to this topic, please let us know, because we would love to feature you and your program in the next webinar. So with that, I'm going to close the webinar for today, and thank you again for participating and for bearing with us through our various technical difficulties. It's been an absolute pleasure to hear from our speakers today and to be working with Sarah and Mark to talk about this very important topic. So thank you, and have a great day or great evening.